Chapter 15, Blood Flow and Blood Pressure. This chapter begins by going over some of the tissues found in the cardiovascular system. I want you guys to be familiar with our blood vessels and the different types of blood vessels we have. So we have arteries, arterioles, capillaries, venules, and veins, and all of these vessels are going to be made up of layers of smooth muscle. Sometimes we refer to that as vascular smooth muscle, since it's part of the vascular system. Elastic connective tissue, fibrous connective tissue, and endothelium. So the endothelium are going to be the cells in which we diffuse across, right? Our fibrous connective tissue is going to provide the rigidity of our vessels, provide them structure. The elastic connective tissue is going to allow for the expansion, and the smooth muscle is going to be the part that is going to dilate or constrict our blood vessels. So if we look at arteries, for example, you'll see that they have the most smooth muscle out of all of our vessels. Why? Because they're under the highest pressure, right? So they need to expand the most. They also have a pretty high amount of the elastic connective tissue to allow them to expand, and fibrous tissue that's going to give them that support so it doesn't blow out. As you move into the arterioles, these are going to be the vessels in which we control most of our blood pressure and the resistance in our system. So we're going to have primarily smooth muscle. Okay, we don't have a lot of elastic tissue. We don't have a lot of fibrous tissue. You'll see in capillaries, all we have is endothelium. In the venules, it's just going to be the endothelium and the fibrous tissue. And then in veins, we'll put in a little bit more elastic tissue and smooth muscle. Now, all of these vessels, the smooth muscle found in these, if they have smooth muscle, so our arterioles, our arteries, and our veins, are able to contract using smooth muscle contraction like we talked about when intracellular calcium levels increase. When they contract, we call that vasoconstriction. When they dilate or become larger, we call that vasodilation. If we look at the cardiovascular system as a functional system in which we're circulating blood through it, what we'll find is that from the heart, from the left side of our heart, right, we'll go from the left atrium, we go to the left ventricle, and we're going to pump that blood out through our aorta. And in the main arteries, we have this elastic pressure reservoir in which with each heartbeat, this is going to expand, and then as the blood travels through, it will contract again. And so this is the pressure reservoir that pushes the blood through. When we move into the arterioles, now this is the area in which the body controls the variable resistance found within our blood vessels. So blood pressure is controlled in the arterioles. You'll see in this drawing, it's kind of drawn like they have these little adjustable screws. But these would be the sites in which we either vasoconstrict or vasodilate the vessels. Then as we move into the capillaries, we're having that exchange taking place as nutrients and blood passes through the endothelium that we have. And then on the systemic side, when we come back into the veins, we'll move through our venules. And then again, we have another expandable reservoir found in our veins in which we can hold blood that ultimately moves into the atrium, right? And from the right side of the heart, we'll pump through and go into our lungs and have a similar systemic circuit. We call this the pulmonary circuit. This is the systemic circuit over here. So systemic, pulmonary. And each side of the heart, it functions as an independent pump, right? So the left side is pumping to the systemic circuit. The right side is pumping to the pulmic circuit of the heart. In addition to this systemic and pulmonary circulation, we also have what's known as microcirculation occurring in our capillaries. Microcirculation is when we move blood through the arterioles into our capillaries. And what we find in these little circulatory pathways is, again, that our arterioles are the sites in which we are vasoconstricting or vasodilating of the vessels to control blood pressure. But as we move into a capillary bed, we have these sphincters that are called precapillary sphincters, and they can basically shut off the capillary beds if there's not a need to have blood flow into those capillaries. And when those close, we can shunt the blood through what we call meta-arterioles, and it kind of bypasses the capillary bed and will move in to the venule and move through. Now, why would we utilize systems like this? Well, if there's not a high metabolic demand in tissue, there's no need to bathe it in capillary blood, right? We can shunt it. Or if blood is needed elsewhere, if we're exercising or shunting blood to specific regions and we're moving it away from others, we'll use these precapillary sphincters. Additionally, these precapillary sphincters, they respond to local paracrine signaling. So the tissue or the cells that are found in this area, if they have metabolic needs, if they need to bring in more sodium, if they need more glucose, more oxygen, what have you, they will produce paracrines that bind to receptors on the precapillary sphincter and will cause them to open. Vice versa, they can also produce paracrines that will cause them to close. So we have this local control that is occurring in each of the capillary beds that ensure that when they need it, the capillaries are open, and when they don't, it bypasses using a meta-arterial. Additionally, capillaries, being the smallest of all the vessels, and the site of where we have this actual exchange of blood and interstitial fluid, they're also the weakest of our vessels. So they're made up of just a single layer of endothelial cells. They're very fragile, and just small amounts of pressure in those capillaries is going to force that blood to move through the endothelial walls. And they do that by their association with cells called periocytes. So these periocytes, they form a layer between the endothelium and the interstitial fluid, and what they can do is they can decrease capillary permeability by expanding and kind of blocking. They also serve the function of secreting growth factors. So if you cut yourself, or there's let's say there's higher metabolic needs in that tissue, those periocytes will secrete growth factors that influence what we call angiogenesis, or the growth of blood vessels, and so we'll get more capillary growth. That angiogenesis, how we get a new blood vessel, this starts obviously in the fetus, and then as children continue to grow, there's a lot of angiogenesis that occurs. In adults, really, there's not as much angiogenesis. It occurs when we have wound healing. So if you injure yourself, obviously in women, on a monthly basis during the uterine cycle, they'll have angiogenesis in the uterine wall. And then in our cardiac and our skeletal muscles. So as we engage in endurance training, weightlifting, those types of things, we'll have angiogenesis that's occurring there as well. What controls this? Well, there are compounds called angiogenic cytokines. So cytokines are a protein that's produced, and these control the angiogenic factors that get produced. One of those factors is called a mitogen. Okay, a mitogen is a growth factor. It promotes mitosis, which you may remember is the cells dividing. So as we produce more mitogens, more cells divide, and we get things, there's different mitogens. We can have VEGF, which is vascular endothelial growth factor. That causes that vascular endothelium to grow. We have a fibroblast growth factor. Okay, and just like we have the angiogenic, we can also have anti-angiogenic cytokines that would stop the production of mitogens. Some of those are what we call angiostatins and endostatins. These may sound familiar to you because they're often prescribed in people that have issues with blood pressure or heart conditions. So an angiostatin or an endostatin sometimes are being prescribed so that we don't have growth of the capillary beds or the blood vessels. Now, the rest of this chapter is going to talk about blood pressure. When we talk about blood pressure, we're referring to the pressure reservoir found within our arteries and arterioles. What causes it, first and foremost, is going to be the contraction in the ventricle, so our systole. When we have that ventricular contraction, what's going to happen is, first off, as that pressure builds, it's going to open the semilunar valve, and we're going to start ejecting blood from our ventricles into our arteries. And as that blood enters, the elastic connective tissue as well as the smooth muscle is going to expand. So we expand the aorta or other arteries, right? And that pressure then gets held because the valve is going to, once we've pushed this out and we've ejected all the blood from the ventricle, the valve will close and it will prevent backflow of this blood into the heart. So there's only one direction that the blood can then travel, and that stretch is going to occur. So we see that here. So as the ventricle starts to relax, we get that what we call isovolumetric ventricular relaxation, where we maintain the pressure. That semilunar valve is then going to close, preventing the backflow. And then we have the elastic recoil of the arteries. So as the arteries then, they've stretched just like a balloon that's been pumped up, and now you release it, that blood is then going to be propelled forward into the rest of the circulatory system. And there's a lot of factors that control blood pressure. Most of these are going to be just factors dealing with the physical parameters of pressure and resistance. So some of these that I want you to be familiar with, first off, blood flow is a pressure gradient, and we're always going to move from areas of high pressure to areas of low pressure. And just as we have this blood flow, that flow is going to be opposed by a force called resistance, right? Resistance to this system, resistance to the movement of that blood moving through it. There's three factors that affect that resistance. First off, the radius of the blood vessels. Okay, so the smaller the radius, the more pressure or more resistance is going to be in the system. The length of the blood vessel. So the longer the blood vessel, again, the more resistance will be encountered. And finally, the viscosity of the blood. So the more plasma protein that we have in that blood, and the thicker the blood is, the more resistance will be encountered. So those three things are going to be vitally important when we talk about blood pressure. The diameter of our vessels, the length of the vessel, and the viscosity of the blood. In systemic circulation, we talked last week about how we have systole followed by dystole, right? In which we have contraction and relaxation. So we have these spikes. If we're looking just in the left ventricle, you can see we go from pretty much very little pressure to, say, very high pressure. This would be at the height of systole. This would be at the height of dystole when we are relaxing. And so we call these two peaks our systolic and diastolic pressure. And we don't measure them, obviously, in the ventricle. We're going to measure them in our arteries. And, an average person, you're going to have a systolic blood pressure somewhere probably between 100 to maybe 180, right? And your systolic is going to be a little bit lower. We say on average that, average person has 120 systolic and 80 diastolic. We can then calculate something called pulse pressure, right? This pulse pressure is going to be those two things, the systolic and the diastolic. So when you go to the doctor's office and they measure your blood pressure, they're measuring the pulse pressure. They get a systolic pressure and a diastolic pressure. Well, if we want to know what the actual mean arterial pressure is, however, rather than just taking systolic minus diastolic to getting our pulse pressure, so if we're 120 over 80, we'd say our pulse pressure is going to be roughly 50, right? But mean arterial pressure we calculate by taking our diastolic pressure, so the lowest, and then we add 1/3 of our pulse pressure. So in this case, it would be 80 plus 1/3 of 50, which is roughly 13. So we'd have like about 93 would be our mean arterial pressure. Mean arterial pressure, it gets abbreviated as MAP in your book a lot, is going to be a function of cardiac output, so how much blood is being ejected, and then which we talked about last week, what influences cardiac output. So it's going to be a function of that and a function of the resistance in the arterioles. We sometimes call that the peripheral resistance. And so we can take our mean arterial pressure and that is going to have this relationship with cardiac output multiplied by our resistance. And if we think about it, what's going to happen to mean arterial pressure if we constrict our arterioles? Well, if we constrict the arterioles, that's going to make it harder for blood to pass through. It increases the resistance, so we would expect our mean arterial pressure to increase as well. Likewise, if we were to decrease, or if we were to take the resistance and we dilated the vessel, so we release that, we would expect the mean arterial pressure to lower, right? Because more blood is going to be moving through this. The reservoir is going to be less. If we decreased cardiac output, so if we lowered this, what happens to mean arterial pressure, right? It's also going to lower. And then lastly, we can ask, okay, we're looking at just on the systemic side, looking at our blood, what would happen if we decrease the amount of volume of blood in our veins? So what that means is the amount of volume in our veins versus the amount of volume in our blood, those two are connected. So if we take less volume of blood, if we store less volume of blood in our veins, that means more blood is going to be in the arteries. So we would expect our MAP to increase. So here, just through these questions right here, we can start to see how mean arterial pressure is being affected by cardiac output in our resistance. I love this figure in your book. It breaks down in very, very simple terms how mean arterial blood pressure is affected. So the things that make up mean arterial blood pressure are going to be our blood volume, the effectiveness of the heart, so our cardiac output, resistance in the system, and then the relative distribution of blood between the arteries and the veins. So first off, let's talk about blood volume, because that's the one we really haven't talked much about yet. Our total blood volume is going to be a function of how much fluid we're taking in, so how much we're drinking, and how much fluid we're losing. So we're going to lose fluid through passive, loss of fluid, sweat, right? And we'll also lose fluid as we filter it in our kidneys and then excrete it in our urine. So you can see right here how our kidneys are going to play an important role in blood volume. Now, effectiveness of the heart, or our cardiac output, we talked about last week. So the two things make up our cardiac output: heart rate and then the stroke volume. And then you can refer back to the chapter 14 slides to see what influences. Like, stroke volume is made up of end diastolic volume, contractility. Those all play a role in our stroke volume. Heart rate is going to be influenced by parasympathetic, sympathetic. Contractility is going to be influenced by sympathetic. End diastolic volume, in some ways, is being influenced over here. Okay, resistance of our system to blood flow is going to be the diameter of the arteries. If we dilate them and make them larger, we're going to have less resistance. If we constrict them and make them smaller, there will be more resistance. And then where we contain the blood. If we have more blood in our veins, then that'll lower the mean arterial blood pressure. If we have more blood in the arteries, that'll increase. So the body has lots of ways, lots of areas in which it can control blood pressure. Look at some examples. All right, let's say you have a rapid increase in blood pressure, right? First, and let's say that comes by because you've increased your blood volume. We drink a bunch of water. Our blood volume then swells as we absorb that water and put it into our cardiovascular system. So the body is going to register that increase in blood pressure, and then we have two responses that occur. We have one which is called a fast response to lower blood pressure. That fast response is going to be directed by the cardiovascular control centers in the brain, and what we're going to see is probably both vasodilation, right? We're going to widen the arterioles to lower blood pressure, and we're probably also going to see cardiac output decrease. So we're going to slow heart rate. We're going to probably lower the contractility of the heart, maybe lower end diastolic volume, okay, to return that blood pressure to normal. So that's going to be a very quick mechanism in which this comes back into normal. However, there's also a slower response going on. We don't want to always keep the heart rate low or the contractility low. We want to remove out some of that excess blood volume, and that's going to occur through the kidneys. So our kidneys will then compensate by increasing their filtration, and we'll see a higher excretion of fluid in our urine that lowers blood volume, and that'll also ensure that blood pressure remains normal once these factors go back to normal cardiac output and normal vasodilation or vasoconstriction. Okay, so how does this occur again? I spoke a little bit about how our arterioles are where we control that resistance. That's the main site of that variable control. And it gets controlled by three ways, okay? We can be controlled by both what we call local and systemic control. So the local control, I showed you that when we talked about the capillaries, how there's local control in the capillaries, but there's also local control that occurs at our arterioles, in which we match the tissue blood flow to the metabolic needs of those tissues utilizing paracrine signaling. Okay, so just like what we talked about with the capillaries, it's there. Now the systemic controls are going to come through what we call sympathetic reflexes. So blood vessels are mediated by the central nervous system, and they are directly influenced by sympathetic neurons. There is no parasympathetic innervation, only sympathetic. And depending on the frequency of those action potentials, we can maintain that mean arterial pressure in a given area, and we can kind of govern as well the blood distribution. So we can be putting blood into the veins, and so on and so forth, using those sympathetic reflexes. And then the last way is through hormonal control. So there are hormones that influence blood pressure. They influence them by acting directly on the tissue of the arterioles, and they alter these sympathetic reflexes. What we see happen is that they are going to cause the vasodilation or vasoconstriction to be greater or less depending on what compound we're using. Additionally, hormones play an important role in excretion and kidney filtering, so they tend to regulate the salt water excretion that occurs in the kidneys, which will affect blood volume. So some of these chemicals, I'm not going to necessarily test over all of these. I don't expect you to know all these, but some of them I just want to point out because we'll talk about repeatedly this semester. So you would expect to see them, in tests, or at least in questions on tests. First off, norepinephrine, right? That's with the sympathetic neuron. It's a neurotransmitter, plays an important role. We talked about we'll talk about vasopressin and angiotensin when we talk about the kidneys next week. Okay, so these play a role, and they're all going to be vasoconstrictors. Okay, for vasodilators, we also have epinephrine, okay, nitric oxide, histamine, is a paracrine that we've talked about. Nitric oxide is a paracrine. And we'll talk about VIP, so vasoactive intestinal peptide, when we talk about our gastrointestinal physiology. VIP becomes a little bit important there. Those would be dilators. Now, I said that sympathetic neurons release norepinephrine, and that they control our arterial diameter. This control is tonic, right? Meaning that we always have some amount of constriction that's occurring. But what you see is we don't have a parasympathetic, sympathetic antagonistic control. It's solely sympathetic. And so if we have a increased rate of norepinephrine release, so we have lots of action potentials, what we'll see is that that's going to cause the blood vessel to constrict tighter, right? But if we don't have as much, so if we reduce the amount of norepinephrine that's being released and it binds to alpha receptors, right, on our blood vessels, then that's going to decrease that tonic contraction and will dilate. So constriction and dilation are controlled by parasympathetic neuron, and it's really just the frequency of action potentials. Frequent action potentials, we have constriction. Less frequent, we have dilation. We monitor blood pressure using special sensors found in the carotid arteries and the aortic arteries called baroreceptors. So our baroreceptor is a sensor, and it is linked to our cardiovascular control center found in the medulla. And what the baroreceptors are responsible for doing is coordinating what we call the baroreceptor reflex response. So what we just talked about in that previous slide, right here, this is the baroreceptor reflex response, this fast response and the slow response of bringing blood pressure back into normal ranges. It's being directed, right, by our sensors, and then we have autonomic and in some cases hormonal reflex controls that then bring it back. let's look at it. Let's look at how this happens. Okay, so we'll take blood pressure increasing again. So our blood pressure increases. As that blood pressure increases, that means our aorta and our carotid arteries are going to expand greater than normal. Okay, the stretch receptors that are in those tissues are our baroreceptors. They respond to that increased stretch, and they send a signal saying, hey, look, the blood vessels, our aorta and carotid, are stretching more than normal. We have a high blood pressure. That afferent signal is sent to the cardiovascular control center, and then we initiate our fast response. Right? That fast response is going to utilize both sympathetic and parasympathetic autonomic neurons. We would see an increase in parasympathetic output. So how that would manifest itself first for heart rate, right? Parasympathetic neurons are going to release more acetylcholine on the muscarinic receptors of the SA node, and that's going to decrease the heart rate. It's going to hyperpolarize the SA node. It's going to take it a little bit longer for it to reach its threshold, and so the rate of the heart will slow down. Okay, that's occurring with the parasympathetic. On our sympathetic side, we're decreasing sympathetic output. What that's going to lead to, first off, in our arterioles, decreased sympathetic output means that we're having less action potentials. And so our arterial smooth muscle is going to dilate. That dilate is going to decrease the peripheral resistance found in the body. That'll help lower blood pressure, right? Additionally, there's going to be sympathetic neurons that are going to decrease their innervation of the heart muscle itself. So the ventricular myocardial contractile cells, they're going to reduce the contractility of that heart, okay? Because they're not going to be giving as much of that sympathetic. They're not going to be depolarizing it and causing it to contract quite as hard. And so force of contraction is going to go down, and that's going to lower the heart rate, or lower cardiac output. Additionally, even the sympathetic output of binding to the beta receptors of the SA node is going to decrease, right? So it's not just that you use only parasympathetic, it's also the fact that you have less beta receptors being bound to norepinephrine, and so that doesn't depolarize the heart as much, and it lowers the heart rate. So all of those are occurring. Ultimately, that restores blood pressure to normal, and we have a negative feedback loop, right? Because the baroreceptors now no longer are being stretched as far, and so they stop sending that signal via the sensory neurons to the cardiovascular center to control all of this. So this whole map shows us our baroreceptor reflex. Please make sure you kind of understand this, how heart rate, cardiac output, peripheral resistance, blood volume, and as well as the distribution of blood between the veins and the arteries can influence blood pressure.